receive questions from Facebook also. So we are looking very much forward to this conversation this evening. And as always, we will begin this evening with a word of prayer that Miss Maxine will bring forward at this time.
Yes, definitely so. Okay. Good evening, our most merciful and loving Father. We offer you thanks and praise for all that you do and are continuing to do in our lives. Father, we are grateful for the love you give us and the grace and mercy that you show us. We are here tonight because this is where you directed us all to be tonight. We could have been out in the street, we could have been out at the park, the weather's great, but you wanted us to be here. You also wanted us to be here because you sent angels in the form of health professionals to bring us important information about mother and baby's issues related to disparities, and particularly Black women. We know in the end, at the end of this presentation, that we will be more knowledgeable advocates. And we know that your name will be glorified because we will give you all the glory for this presentation. We pray for the leadership in this event. We thank you for their insight. And as we start this program, Father, we give you glory to the most heavenly Father, and the people will respond by saying amen.
Amen.
Amen. Thank you.
So good evening, everyone. My name is Deborah Levine. I am the director of the Harlem Health Initiative for the SUNY School of Public Health and Health Policy. And it gives me great pleasure tonight to partner with two of my congregations and two women who I have worked with well over the last 10 years. And it is such an honor and a privilege to be in a role where I'm able to work with them once again. And you will hear from these great women further on into this presentation. Without further ado, I'm going to turn the floor back over to Maxine, who will guide us through our first part of our presentation this evening to set the tone.
In setting the tone, I'm going to do the role that my coworker would have, but she's not feeling too well today. So this is her speech. This discussion came about because of results of her own personal and professional awareness of this issue. This awareness did not come suddenly, but it was a slow, dawning thing that she had questions, probably that should have been answered years ago. It seems like she lost her baby, her own baby at 5 months, and it was a horrific experience. Her sister and her daughter also had stillbirths. Her awareness started when she began her career at Bellevue Hospital as a social worker in the prenatal clinic and on the OB inpatient unit. It blossomed when she started to manage the clinic, the inpatient unit, and the neonatal ICU. She now sees fully what happens in the full circle and the effect and impact on differential treatment. We're talking about the treatment for minorities, Black women, as opposed to their counterparts. Because of her experiences and the ones she's been exposed to, she became an advocate for these women who could not speak for themselves. She realized that it's crucial for women to know what is right and what is wrong. And if something is wrong, how to address it. So here we are today with experienced and knowledgeable speakers who can inform and enlighten us regarding some things that have gone along too far. So thank you. I will now turn it back to Deborah. You mute, Deborah.
Sorry, can everybody see the screen?
Yes, I see it screen.
Okay.
This is Victoria Rexach. She was 31 when she went into labor with twins. I've come to meet her mother, Robin Davis. You've got a lot of pictures, haven't you?
I love my pictures. I do. This is Victoria. She was out on her birthday. And someone blew this picture up for me, and I was so grateful. So that's Victoria.
What does she mean to you?
Everything. Everything.
Just call the toll-free number on your screen now to see if you qualify for Medicare-Advantage plan. It may include free eyeglasses, free hair, free meal delivery, free prescription drug delivery, expanded at-home telehealth visits, and much more. You may be eligible for a 2021 Medicare Advantage plan with additional benefits that can help you meet your healthcare needs. Remember, don't get these benefits automatically. I want it.
No bio.
Call now. There is no obligation to enroll. The call and Medicare benefits review are absolutely free. Just call 800-422-0651 now. That's 800-422-0651. That's the number.
Does anybody hear?
No, we don't.
What you mean you in so much pain?
We don't
Did they give her epidural? No, they didn't. They gave me potassium. I said, what? Why
Miss
would-
Deborah, mute your phone. We can hear you, Miss Deborah. We can hear you,
Why?
Miss
She said,
Deborah.
because, my water broke and I wasn't having no labor pain, so they gave me
Miss
that.
Deborah, we can hear you.
Is a drug commonly used to induce labor. According to Robin, Victoria's previous pregnancies were complicated and her other children were delivered by C-section.
Victoria was told that her uterus was weak. She was told by her doctor. She had to go to the doctor every week. When she went into labor, she should never, ever have given vaginal birth or given any type of medication to stress out her uterus. And because of that, her uterus ruptured.
During the birth, Victoria suffered massive blood loss and died.
I felt like all the blood rushed from my head over to my feet. I said, I gotta get out of here, I gotta get out of here. I said, I cannot believe that this is not happening, it's not happening. I just couldn't grasp it in my head that that's what happened. I wanted to have the city medical examiner do an autopsy on Victoria because I didn't want the hospital touching her no more. So I went downstairs and then the doctor who was with Victoria comes in, who made all the decisions. I wanted to ask her 1,000 things. How was Victoria that day? What was she doing? Did you talk to her? Did you ask her, was she okay? Did you show her compassion? Like, even if it was fake, did you show her anything? Like, how was she that day?
Robin wanted to show me exactly how her daughter died. Are you all right? You're okay. So this is the office of the chief medical examiner. So I'm just going to read a little bit.
Yeah, you can read it to me.
God, it's really sad. The cause of death is a hemorrhage due to ruptured uterine scar following vaginal delivery of twin fetal demises. So she gave birth to 2 of the babies. Both of them died, and she gave birth to them. I mean, I just wanted to read you some statistics. I wonder if you know that if you are an African American, if you're a Black woman, you're up to 4 times more likely to die during and after childbirth than if you're white. In New York, it's even worse. It's up to 12 times more likely to die if you're Black in childbirth or just after.
That's the worst thing that I've heard. That's bad, and I didn't know that. I wish I would have known sooner, because had I known this and what the statistics were and what we were up against, I would have been there. You can actually, it could be prevented. You could be helped a little more, but you're not because of the color of your skin. it makes me angry. It just makes me more angry than I was before, because now I know what I was feeling was true. You know, my assumptions are not assumptions anymore. It's coming into reality, and it's making me a little bit scared. It's scaring me because what the heck, what's going on? I have daughters that still can have children. What does that mean for them? Like, I don't know, it's scary, it's scary. This is my Victoria.
We wanted to share with you just a piece of that film to set the framework. Although that YouTube may be a few years old, the story doesn't change in the least bit in where we are currently. What I would like to do is have our speakers come forward. We'll first have Minister Rolle, who will talk about her research in maternal health and her findings, and then have Dr. Terri-Ann will talk also about her experiences and how you can recognize racial disparities and addressing them. And Desiree will come and join us as a CNP to talk about what she observes in her practice around women and babies. This is also Women's History Month, and we want to acknowledge that, along with also acknowledging that it was on the 10th National Women and Girls HIV Awareness Day. Yesterday was also International Women's Day. And with all of the light that we are putting forward on our women, we are still faced with horrible percentages in terms of our care, in terms of our outcomes. And so here is an opportunity for us to have a conversation, to build some skills about what we can do as individuals, what we can do in the organizations we work with, how we can share this information with our family and friends. So I'll ask that Minister Rolle come forward. Ro, come forward, and I'm sorry, I don't see you. There you go. And
I'm sorry.
you are unmuted.
Good evening.
If you would give us your intro and your presentation. Thank you.
So I'm sorry. I have to use my phone because my computer's not acting right. So I'll do the best that I can. I'm Reverend, not Minister, Reverend Caiphia Carolyn Rolle, and I'm also a registered nurse. I'm a graduate of Harlem Hospital School of Nursing, Harlem Hospital School of Nurse Anesthesia. I graduated from Pace University and recently graduated from Helene Full College of Nursing over here on Madison Avenue and 120th Street. I am an ordained Baptist minister. I am presently working on a doctorate in ministry as a fellow at Adam Clayton Powell Fellow at New York Theological Seminary. My focus is justice. I'm trying to do I'm trying to do something in regards to making the world aware of the fact that there's such a high mortality rate amongst Black women in this country, a maternal mortality rate. We've known since about 2000 that there was a high infant mortality rate, but now I don't think as many people were aware of the fact that there's been a maternal mortality rate as well amongst Black women. at first it was a maternal mortality rate with everybody, but then when people became aware of the fact that it was the maternal mortality rate existed, people began to work on it, but then they just left Black people out of it. And when the numbers began to decrease, they began to decrease with it for everybody except us, except Black women. When I say us, I need to specify not Black, any Black people, but Black African American Black women, because Black women is anybody that, according to the United States, anyone that has one drop of Black blood. But in this particular instance, it's Black African American women whose numbers are not decreasing. The numbers that I have, the statistics in my studies so far, have shown that African American women are more likely to die than white women at a rate of 3 to 1. To find my numbers too. Sorry. African American women are more likely to die than white women at a rate of 3 to 1. Sometimes, in some instances, depending upon where it is, in the state of California, at one point it was 12 to 1. New York is 3 to 1. The numbers vary throughout the states. This year is the first time they've gotten statistics on a regular basis where so that they can tell by looking at the statistics on birth certificates throughout the country, regular on an annual basis, exactly how many deaths have occurred, so that they can know, so that in order to be able to do something about refining reproductive issues and taking care of what is it I want to say? Um, making progress in caring for the people that are in need of making progress and taking care of the needs of the people in the states that need to be done. There are laws that are being, we need legislation in all the states. We're trying to get some federal legislation done in all states in order to make some reproductive progress, because there has been no progress in regards to reproductive needs for the people in the United States, because the United States at the present time is last in all of the developed nations as far as in all of the developed nations as far as infant mortality and maternal mortality rates. Presently, the infant mortality characteristics of people of individuals who have characteristics of individuals in characteristics of individuals involved in infant and maternal mortality include the non-Hispanic Blacks. The highest infant mortality rates at the present time is 10.4. African Americans are 2 to 0.3 times more likely to die giving birth. Over twice have due to sudden death syndrome since 2017. African Americans were 2 to 3% more likely to die than anyone else. The causes include low birth weight, congenital malformations, maternal complications, unintentional accidents, and sudden infant death syndrome. Some of the infant deaths and mortality rates for the top 5 leading causes of death for African American per 100,000 deaths in 2017 include low birth rate, congenital malformations, maternal complications, unintentional injuries, and sudden death syndromes. The number of deaths for low birth rates for African Americans were 3,354. I don't need to go through these figures. I won't go through the figures, but they because they're too many and I don't have that much time. The age is a significant factor in the deaths for African American women. The age factors include women under 20. At one point, the teenagers were a higher number of deaths. At this point in time, we don't have as many youngsters having babies as we had at one time, which was a factor because the younger children having children were also dying at a younger age. Up until 2017, the numbers of children having children has somehow decreased. They're not having children as young anymore. One of the factors of mothers dying in birth also seems to increase with age. We seem to have women that are over 40 included in the numbers of women that are among those that are dying at birth. It appears that as you age, you are at increased risk of dying at birth while giving birth. A lot of that has to do with the fact that as a lot of us that are older run into increased incidence of death based on the fact that we have the issues that relate to death at giving birth, and those incidents include obesity, hypertension that come with age, and the fact that far too many of us are inflicted with, as Black people and Black women, the issues that include such problems such as fibroid uterus and other infertility issues. With those infertility issues and the incidence of hypertension as well as obesity come issues that will lead to contributing factors as well as diabetes that will lead to complications that will cause complications that will, with those issues, lead us to factors that will lead us towards issues that will lead towards the complications that increase the incidence of the possibility of morbidity or mortality. With that comes stress. With the stresses and the incidents in life that include factors that lead to things that we have nothing to do, no control over, such as factors that lead to stress, such as the disparities that have caused the incidents that we are left with talking about, such as racial incidents, increased racial incidents that lead to the discussion today about I'm sorry, about
Mortality.
no, I'm trying to talk. I'm trying to say that we I'm trying to
Well, Pastor, when you
no. Why there are many articles that are written about why Black women are dying that at such a high risk for dying, and all of it has to do with the very high incidence of racism. That's what I'm trying to say. Structural racism, and structural racism and systemic racism. That's what I was trying to get to. And the systemic racism that is a result of things that have nothing that we have anything that we can do anything about ourselves. And the systemic racism and structural racism that exists, that we are in discussion about, that has to do with us not being treated the way we should be, because of the fact that there are certain situations where we are not given the kind of treatment that we should be given. We are not given the referrals that we should be given by certain doctors in certain communities. There are articles that are written and factors that are in existence where Black women are not given the amount of referrals that they should be given. Black women are not given the amount of not just referrals. They are not given the same referrals that they would be given in a white community. So as a result, we suffer. We are not treated the same. We all know that in situations where a white person or someone else would be told to eat a certain kind of food or take a certain kind of vitamin or something, we are not, and as a result, we would suffer, and they would not. There are statistics that have been found to been taken, and it has been determined that we are not always given the same vitamin suggestions that people, other people, or white people are given, and they fare better. So they're the reason that we die faster or we have more complications is because we are not treated the same. I read an article that was written in like 1990 something about how malpractice insurance began to increase for obstetricians in such a way that Black obstetricians had to discontinue practicing in the Black community because the malpractice insurance was so high that they had to discontinue practicing because they couldn't afford to practice. That took that group of people, Black persons, out of the Black community, taking away, leaving only white obstetricians in the community, meaning that group of people that were available to provide services for Black women was missing. So therefore, the numbers began to increase in Black and infant and women mortality. It coincides with the malpractice insurance going up, and the mortality rates beginning to go up. If someone were to do some research in that matter, which came to my attention. I don't know.
Thank you, Pastor. That's really a very critical point that you're raising. And I want to bring into the conversation Terri-Ann, who can also share some of her experience and the work that she's currently doing as it relates to Black women and girls and babies.
Hi, good evening, everyone. My name is Terri-Ann Bennett. Thank you so much for having me here today. My role currently is I serve as a maternal fetal medicine specialist at NYU Brooklyn. And I also serve as the director for recruitment and retention in our Office of Diversity Affairs at the NYU Grossman School of Medicine. I am a Jamaican-born immigrant, actually, but I migrated here when I was 3 years old. So I spent most of my life between South Florida and the Bronx, which is where most of my family lives. I completed my undergraduate and medical school training at the University of Miami before returning back to New York and doing my residency in obstetrics and gynecology, and then a fellowship in maternal fetal medicine, which is basically just high-risk pregnancies. So my job is to take care of women who are pregnant, and particularly women who have high risk issues. So that can range from a multitude of different things, from having high blood pressure to diabetes, to even more serious medical problems like heart problems and things like that. I also care for mothers who are unfortunately going through pregnancies that may have fetal complications. So that can range from like a Down syndrome or other genetic disorders to structural abnormalities like the baby has a heart defect or a problem with another part of the body. So there's lots of different things that can make mothers high risk. My passion really lies in preeclampsia, which is a high blood pressure complication that can happen in pregnancy. And many of the videos, actually, if you find online, actually end up stemming back to preeclampsia. Preeclampsia is basically where you get high blood pressure in the third trimester typically, but it can happen at any point throughout the pregnancy. It's usually associated with like protein in the urine. It can affect your kidneys, your liver. And in very severe cases, it can cause seizures, stroke, and even death. Black women tend to have a higher incidence and prevalence of preeclampsia in pregnancy compared to their white counterparts. And preeclampsia and high blood pressure complications in pregnancy have been well documented as always, usually in the top 3 causes of maternal mortality, particularly in the United States, but worldwide. I've done a lot of international work as well. I served as a chief operating officer at a field hospital in Haiti after the earthquake. And I also have worked in Jamaica, which is my home country, and Ghana, which is my second home country, that I've adopted in West Africa, where I saw things there taking care of Black women that just blew my mind in regards to how hypertension really affects our bodies and how it can really be such a devastating disease. My other passion lies in preterm births, because that also tends to have an inequity when looking at Black women compared to their white counterparts. In some ways, preterm birth can be prevented, but in many ways, it's a very complicated syndrome that requires a great coordination of care and close monitoring. And my other passion is about maternal mortality, and that's what I do a lot of talks on. I give grand rounds at different institutions and within my own about the social determinants of health, which is a lot of where my focus is right now and where my future research will lie. And what that basically means is looking at why are Black women dying to have a baby. We know that our maternal mortality rate in the United States is abysmal, and it has been worsening for a long period of time now. And I'm glad that it's getting a lot of attention so there can be policy change, which is really what we need. But in this conversation, I really want to focus on 2 things: what my work is in regards to helping to change some of this in an academic setting, but also what we can do as a community, as individuals, as family members, as sisters, as friends, as cousins, to help each other, which I think is really important. But I also find it to be the most important to not focus on the patient factors and put the onus back on the patient. I think a lot of times in academic medicine, obviously I work for a big institution, but I think what happens a lot of times in academic medicine and in medicine in general is we usually try to find a way about how did factors related to that individual cause their outcome or cause their complication or cause their demise. A lot of times we reflect back on some of the inherent factors of that person, such as their high blood pressure diagnosis or their diabetes diagnosis or their obesity, et cetera, or their lack of prenatal care or late initiation into starting their prenatal care. And a lot of the talk in many years has been focused on putting the onus back on the patient. A big part of what I've been doing in my most recent part of my career is putting some of that back on physicians, because I think it's our responsibility to decrease this disparity and to eliminate this inequity in healthcare. Because a lot of this has to do, like with what the Reverend was saying, with institutional and structural racism, and how racism is the risk factor and not the race. And so what I've been working to do is to really focus on educating my colleagues, especially in these big academic centers, about how racism is causing Black women to die and not their race being the factor, but also how structural racism, how our own explicit and implicit biases are affecting how we deliver care to our patients, how they interact with our health systems, especially these big white institutions when it comes to minority mothers, and what we can do as doctors to put the onus on us, how we can build trust within the Black community, especially because there's been a lot of racism in medicine for decades, and we all are very much aware of that, I'm sure, in this circle. So another big talk that I give frequently is talking about the history of racism in medicine, because doctors don't know this stuff, to be quite honest. They don't know a lot of the social factors and the implications of what those things have done to us as a people, much less as Black women. For me, I entered this field because when I was a young Black girl growing up, I had a great mentor who really taught me how to learn about myself, my strength, and the impact that I can have on this world. And so I use my energy and my strength and my knowledge to take care of women, because I think that Black women are the wave. I think that we are the future, and I think that we're the backbone of this entire civilization. And so if we're going to save the world, we can only do that through Black women. And most importantly, my goal wasn't really to save the world, but really was to save the Black family, which most certainly can only be done through the Black woman. And so my focus is really teaching doctors how to be better doctors to us, how to teach people how to understand racism and its implications, how to teach doctors how to build trust within minority communities and to put themselves in a position where they're figuring out, what can I do to help this person, not sort of pointing to the finger at the different things about that individual that can cause their complications. And so I'm happy to take questions. I do want to leave some room for that. I obviously can have a lot to say. I can talk about a lot of different things, but I'm interested to hear what you guys would like to hear from me. I'm an open book. I'm a very frank speaker. I'm very honest with my patients, and I plan to be very open and honest with each of you. So I want to leave some time for questions, because I can go on a lot of different segments. So I want to hear what you guys want to know.
Great, and we appreciate that. And I'm so glad that you brought up the social determinants of health, and we'll get right back to those. But I do want to give Desiree an opportunity to come forward and to share her experiences. And you will notice that I am being very informal, because we really want this, and I have asked these women permission to call them by their first names. So I don't want there to people to feel like I am not respecting the roles and the titles, but we wanted to make this a conversation where we could have open and honest dialogue in a way that allowed one to share. So please, Desiree.
Hi, everyone. Good evening. My name is Desiree. I am a registered nurse. I'm also a nurse practitioner. I received my nursing degree from Hampton University and graduated in 2013. And then 2015, I attended Binghamton University, where I received my master's in nursing as a family nurse practitioner specializing in community health. And I'm currently a PhD student at Binghamton as well, pursuing my PhD in nursing and focusing on resilience and spirituality amongst patients with chronic illness. And so my role, or what I've been asked to do tonight, is to kind of speak from the nursing perspective and how to be a better advocate for patients. And so some of the things that I wanted to touch on was, first, as a clinician, as a nurse, is to, and I think with all healthcare providers, is to check your own bias. That's one of the big things that going into medicine, you see so many different patients of different cultures and different backgrounds, but being able to acknowledge that bias and being able to acknowledge that you yourself have some sort of innate, predetermined thought about patients is one of the things that we need to check. And particularly when it comes to Black women who are explaining or, presenting problems, or they're, especially, moms to be, they're very nervous, especially first time moms. I can only imagine the types of questions and the anxiety that they go through. So as a clinician, checking your bias, and we all took the Hippocratic Oath. And for me, I took Nightingale's Oath. And one of the big things is to do no harm to the patient. One of the things under do no harm is to educate and to really provide a supportive environment for your patients to be able to trust you. And I think Dr. Bennett had touched on that earlier, establishing a very good, firm, trusting relationship with your patients is one of the big things in kind of facilitating reducing mortality, right? Like, they have to trust you. The second thing that I look at, especially looking from a community health perspective, is the utilization of services and providing services in the community. And so that comes along with funding, that comes along with, having the information present and utilizing faith-based organizations as one of those citadels, or like one of those places where these patients actually trust. A patient sometimes will trust a church before they trust a doctor. And sometimes that's the sad truth of it. They will trust their faith leader, and they will bring all their problems, all their health problems to church and leave it at the altar. So utilizing faith-based organizations and presenting services and resources for these patients is very important. And utilizing other members of the healthcare team. Of course, OB, GYN doctors are top priority because they provide the medical knowledge. They are the ones who facilitate birth, but also looking at different components of what a healthcare team is: midwives, doulas, nurses in the community that can help provide emotional and spiritual support as mom is journeying to bring life into the world, is one of the things that we as Black women should be aware of and know that these services exist. And the third thing I think is that's super duper important, especially from a healthcare standpoint, is lobbying to push for policy to support these services. Nothing really gets done without money. And so really pushing policy and really pushing and lobbying for those things to happen, especially in our community, is an important part in helping to reduce mortality. We are the ones who make this thing go round. And so really pushing our political leaders to say, listen, we are willing to save ourselves, but we need you to put these laws and these policies in place to protect us, to protect our children, to protect our families. So those are, some of the things that I think are important, even from just a nursing standpoint. I work in a hospital still as a registered nurse, and I also work as a nurse practitioner doing COVID testing. But, being the advocate and understanding that the cultural implications and being sensitive to just what the patient needs and listening is one of the biggest things that we can provide. And for people who are not healthcare providers and who are not in the clinical realm, being there, family support is a really, really big thing. And I know COVID has turned everything upside down on its head. So, having a whole bunch of people there at doctor's appointments and L&D while mom is laboring, it has been put on hold, and a lot of that has put a strain on mom and the staff, but still somehow trying to find innovative ways to make the patient feel supported, make them feel like they can trust you, and make them feel like you are truly working in their favor is one of the things that nursing has to stand for as a discipline. So that is my little spiel, but I'm definitely looking forward to this fluid conversation.
So thank you very much, and I appreciate that. We're going to move into opening the floor for some conversations, and we have some questions already in the chat box. So I'm going to ask folks if you'd like to ask a question or participate in the conversation, please feel free to either put your question in the chat box or signal to me that you have a question, but I will start with the ones that are in there already, if that's okay. Dr. Bennett, Desiree, there's a question about what is a doula and what is the role of a doula in the chat. If either one of you would like to address that. And maybe Desiree, you can start, and Dr. Bennett, you can talk about how doctors work with doulas.
Okay. So the difference between a doula and a midwife, a doula is a trained non-clinician, so they can't give medical advice and they can't prescribe medication. They can't treat the patient medically in that sense. However, but they do have an important role, especially as mom is laboring, to provide emotional support, spiritual support. A lot of moms I see use doulas when they're doing home birth, but they, check in on mom, see how she's doing. Even up well after postpartum, you'll see doulas checking in with mom, checking in on baby, seeing if they need anything and providing the necessary resources to help support mom's journey from labor to right immediately postpartum. And I've seen some doulas even follow up with patients months after they've had baby just to make sure that they are good. And research in the literature has shown that having doulas present definitely reduce the use of C-sections and the use of pain medication. And so they do different modalities such as massage, therapeutic touch, aromatherapy I've seen. And it just provides like a different, again, like just a different arm into this whole machine that works together to help bring mom and baby or bring mom to have a safe delivery. A midwife is they could be a certified nurse midwife, where I've seen some programs where you could go straight into a midwifery program, but these are trained clinicians, and they work in OB offices, they work in hospitals, and they also assess mom through pregnancy. They can facilitate a labor, and they could give medical advice. And obviously, if it's out of their scope, especially when it comes to high risk moms, they will definitely have to bump that up to someone such as Dr. Bennett, who specializes in high risk pregnancies and high risk births. But the difference is, one is a trained clinician, and you have to go to school, you have to sit for a board exam, you have to have clinical hours. Doulas, you do go through a program and you do have to have some sort of clinical hours, but you do not provide any type of medical advice. But they both, I believe, are really necessary when it comes to painting the clinical picture. You have OBs, again, who like kind of mans the ship and kind of gives the medical advice, monitors mom all the way through pregnancy, labor, delivery, sometimes C-section. But then you also have like these extra components that kind of make the experience that much more meaningful and that much more trustworthy when it comes to the patient, if that makes sense. And Dr. Bennett, you could jump in whenever you're ready to.
Yeah, I agree with everything that you said. I think of birthing as a team sport. And so the best way to go about thinking about that is that it requires a multitude of different types of specialties. And so that ranges from doulas, which for me, on a personal level, doulas are kind of like if you were going to a foreign country or visiting a museum and you had a guide. From a clinical standpoint, I think about doulas as a patient advocate, so to speak. There's someone there to really have the back of that birthing person and to help them through the process and to kind of remind them what they wanted their birthing experience to be like, and to help to guide that sort of emotional and physical journey through birthing a human in a way that that person envisioned it to be. And everyone has a different idea of what they want their birthing experience to be like. But for me, the doula is really that patient advocate that's there to stand in with the patient. But I think it's also important to recognize that doulas aren't just important during the birthing process on L&D. You can actually have doulas throughout your entire prenatal course. And there are a lot of programs that actually offer free doulas throughout New York City. And there's dollars that's state funded and city funded to support Black mothers to have doulas in the birthing process. Even during the time of COVID at our hospital, we're still allowing support people. So when it was, really crazy back in March, April, we were only allowing one support person, usually the partner. Now we are allowing doulas who, certify that I'm a doula and the birthing person's partner, because we really think that that support and that team approach to birthing is really important to having a good outcome. I know you mentioned midwives on our labor floor too. We also have midwives at NYU Brooklyn. So we have a very collaborative approach to the birthing process. You have nurses on the floor, RNs, many of which also are doulas. People come with their doulas that they pick and pay on their own or through one of our through one of the programs within their cities. You also have your obstetrician, and hopefully you don't need me, because that's usually not always a great idea. If I'm there, that means probably something bad is happening, but also a high-risk doctor if necessary, because also my job is to prevent you from having a bad outcome. And so I really think that that team approach to birthing is extremely important. And I really think that as Black people, Black women especially, we need doulas. We need patient advocates throughout the entire prenatal course. One thing I find, unfortunately, you know, we got to put some of it back on us, is our own education of our bodies and our own education of feeling empowered to advocate for ourselves. And when you're on the labor floor and having a baby, it's going to be real hard to advocate for yourself. So that's one reason why I think on the labor floor it's particularly imperative. But really throughout the entire prenatal care, you need someone there to, oh yeah, remember you wanted to ask this question? Remember this came up last week and you wanted to inquire further about this? That person just really there to have your back and to join you for the journey and to advocate for you throughout the whole process. And with that, it really is to help to make sure that all the right things that should be happening is actually happening. And there's a lot of ways for us to empower ourselves and our family members with that, because there's lots of guides online now. And I think people aren't aware of that, but the CDC has guides. The American College of Obstetrics and Gynecology, ACOG, has guides. The Society for Maternal Fetal Medicine, which are the high-risk doctor society, also have guides. But basically, what I think is most imperative is if we empower ourselves and you're being a part of your care team, because you're also a part of the team. Like, I think we can't forget that part, that this is your body, this is your baby, this is your pregnancy, and you're a part of the team as well. And so being empowered to sort of be an active player in your care really would go such a long way in saving Black mothers.
Thank you. Pastor, did you want to weigh in? Okay, I see that Maxine, you have a question.
Yeah, mine is more of a comment, thank you, because I had the privilege of being an advocate for my own daughter. I'm a nurse, in case everybody doesn't know. And my daughter did have a doula and a midwife for her whole pregnancy. And the doula was sort of annoying to me being a mother, because she would say, oh, you have to leave her alone. She needs some rest. She needs some sleep. She needs some soup. She needs some this. Let me rub her feet. Let me rub her back. Let me do this. She did everything in my house all the time. She was an amazing, amazing woman. And then the midwife was great too. Not to put anything down, Dr. Bennett, but when my daughter did deliver, and this is just my experience, we locked the doctors out the room because my daughter didn't have any complications. So we went to the room. She had soup, we had sandwiches, we sat in the bed. They told her how to deliver. As a matter of fact, she delivered on her knees. We delivered on her knees, and I cut the cord. But that experience was so wonderful, and that experience that everybody doesn't get that if you don't know about it. You need to experience it, and you need to have knowledge about what is available. This is in Harlem. The doula was living here, the midwife was living here, and we had a fantastic birth with my first granddaughter. So again, education is important, knowing where things are and who you can get to help you if you need help. That's what I wanted to say. Thank you.
I love that you brought that up, actually, because one thing that I see happening is kind of like this fear of doctors, obviously, this fear of hospitals and fear of systems. And I really think that that's harmful for us as Black people. There are opportunities where having a midwife is perfect and you don't need a doctor in the room. I'll be the first to say it. I mean, I'm very close with a lot of my midwives. I learned from midwives. I text my midwife friends sometimes right now when I need some advice on something. What do you think about this? Well, I have a friend not in labor yet. What would you do? Like, I definitely think that there's a collaboration that's essential, most certainly between the team members, but the doctor is not always needed. That may be true. But I do think it's important to recognize that there's levels to this. And for some people, that may be the right route. I'm so happy that your daughter had such a beautiful experience. But for some people, especially if they have a comorbidity, like a medical issue or anything like that, they may need to be in a situation where the doctor can just scoop right in, or the high-risk doctor is right there to scoop on in. And I think that's very important to recognize each individual experience and that everyone's going to need a different level of care.
One of the task force, the governor had a task force investigate the amount of maternal mortalities in the state that was that began in 2016. And one of the recommendations for that the task force gave was that the state began a procedure or process for educational opportunities for people in the state to have schools where you certify people to become doulas throughout, educational opportunities for doulas to become certified throughout the state, and maybe give them scholarships or something of that nature to increase that, so that we will have those opportunities for people to increase that and fill in that need and for that need in the community on a grassroots level, and in order to decrease the as part of the decreasing the death rate, and part of the assisting in improvement of reproductive issues in the community on a grassroots level.
If I can add to that, from that same task force, I'm familiar with the one that you're speaking of. In addition to putting money to help train more doulas, there's also money so that you can get a free doula. And I think people don't know that, because I didn't even learn about some of the free doula programs in Brooklyn until I was preparing a talk like many years ago. And I discovered that there was a program where my patients could be getting a free doula. And I was like, what? Like, I want to give all my patients a doula if I can. For some people, it may be cost prohibitive, but in many cities, actually, you may be able to get funding through the government because of these task force. So something also to keep in mind into research.
Excuse me. There's one politician, I don't remember his name because it's just listening to it, but he's running on providing doulas, a certain number of doulas, if he wins. He was running for mayor. And we had a big conversation about it on NPR a few minutes ago.
A question though, in response to that, what other things that the task force recommended are you aware of having been enforced? That was one of the questions that I had, and I had no way of knowing whatever about anything else that was recommended. Educating people in regards to the racial issues that came up out of the things that came out was also recommended, but I don't know if anything was ever initiated. Could you answer that, Ms. Bennett? Dr. Bennett?
Not too bad.
Yeah, so a lot of what the task force has suggested, a lot of it is tied with money, like everything else. So I think one important thing from the task force is for there to be some policy recognition so that the money can trickle where it needs to go. A second part of that is sort of some of the changes within hospital systems, which many of them are being implemented. So New York State itself actually has implemented quite a few things in the progress of the task force, even more so. And that includes like maternal mortality review boards, which means that like when a mother dies, there is a review process that goes on where a lot of times this happens to our Department of Health, where those charts are collected from those hospitals and their entire prenatal care and postnatal care is reviewed. So there can be sort of a reasoning found behind it. So there can be implemented change. Some of the things that have also trickled down the pipe is looking at not only the reporting of maternal mortality and risk factors, but also looking at hospital rates itself and seeing how to implement certain policies within each hospital. So many, particularly the large academic centers I can speak for, have what's called evidence-based medicine protocols, where something that was mentioned, I think during your speech, was about how Black people don't always get the same care, which is very true. So a lot of what these evidence-based protocols are trying to establish is sort of so that everyone gets the same care. I'm a proponent of that to a degree, because I want us to get what's essential, especially for Black and brown people. But I also want there to be some room for individualized medicine, because I don't want to be treated the same way as the white woman who's my age, because I already know that my outcomes with her are not the same. And that even my education level, I mean, if I count, it's a lot from high school, 4 years of undergrad, 4 years of med school, 4 years of residency, 3 years of fellowship. Somebody do the math, and that's like 17 years post high school. And that's still not going to save me from the statistics of there being a heightened risk for even me as an educated Black woman with a professional degree from dying to have a baby. So a lot of what these policies are trying to implement is to standardize care so that at least the basics, the essentials, the evidence that we know what works is happening for everyone. But there also needs to be room where we need to treat people differently based on their risk factors and their current situation as well, so that we can make sure that Black women aren't dying under the same circumstances.
And I'm gonna put the link for that report in the chat if folks are interested in taking a look at that. The task force actually is the one from the Bronx Borough President.
Okay, good night.
Sorry, Desiree, I saw you had your hand up. You wanted to contribute to that. Go ahead.
And I'm kind of like drawing a blank on it. In talking about birth and the labor process, I think having a birthing plan and starting super early is one of the things that we need to also support. And again, the team effort of having an OB, doula, midwife, and kind of painting what you want your birthing experience to really look like. Some women don't know. And some women are just like so nervous and excited and scared at the fact that they're going to be bringing life into the world in, 9 months. They don't even think to have a plan because things can always turn left, turn right. So even just having just a base plan to say, okay, do I want pain medication? Do I want an epidural? Do I want it to look like this? And as Dr. Bennett had touched on earlier, while you're in labor, the last thing you're thinking of, okay, stick to the birthing plan, right? That's where you have everybody on your team to kind of really help you say, okay, Desi, this is what your plan is. Like, are we still sticking with it? Are you okay with this? And kind of coaching you through the whole process. And I saw a question in the chat about like, what can men do? Men can be part of this process. They are very pivotal, important, integral part of the pregnancy, the laboring, the delivery process. They can support and do roles that the doula can do, and supporting mom and providing that emotional and spiritual support and being an advocate, right? And so even if you feel like your team isn't, and excuse me with this loud car that just passed me, if you feel like that your care team isn't providing you being an advocate for your partner, for your sister, your cousin, whoever you are serving in that moment, you are just as important in providing education, receiving education, providing that support that is so needed for mom as she is going through this experience and through this process. So don't think that you are not, your role isn't there, figure out what you can do. You can do so many things, and support is one of the biggest things that you can provide, and being there along the way, right? Going to appointments. And I know a lot of stuff is virtual now, again, because of COVID, but arming yourself with all of that knowledge. So when the time comes, you can say, okay, I prepared for this kind of, and I know this, and I heard these words before. It just provides a better experience, and it definitely reduces the stress, the anxiety, that comes with labor and delivery, and just even pregnancy altogether.
Yeah,
I want to add to that and say that I think the role for men also is afterwards, with postpartum depression and being there to support. And so that role never stops, even after pregnancy. And sometimes I think it's even more critical afterwards, just the exhaustion and the role of a doula and following up afterwards and having that support becomes so critical. I'm just looking in the chat, and there was a question here that can diet work to prevent preeclampsia, or do we really have to take baby aspirin every day and the diet work together? Dr. Ben, I'll pitch that one to you.
No problem. I wanted to echo what Desiree was saying as well about the men being a part of the process. Because there is nothing that excites me more than when I'm in a prenatal visit. And just because it's COVID doesn't mean you can't be a part of the prenatal visit. You can be right here on the phone, on the FaceTime, right next to your partner, just like how you were before, just not in the flesh. So I still think there's a way for partners and men to be a part of the process. Because I'll tell you, when I used to have my dads come in the room and they knew what today's appointment was going to be about, and they knew today was a sugar test, or, hey, doc, this thing came up, what about this? I would be so hyped when the men were like so integrally involved and they were writing notes and they were being an active part of that process as well. Because those links that I mentioned about being an active care participant in your own care is not only for that birthing person, it's for their partner as well. Because just as she can read about, okay, it's the first trimester, here's what to expect, so can the man. And that, I think, is a good way to be able to be even more supportive of her throughout the course of the pregnancy and what you mentioned up until the postpartum period as well. In regards to preeclampsia, so the truth is, I'm a truth teller, so I just have to keep it real. The truth is that we don't really fully understand preeclampsia to this day. There's a guru, he works in Texas actually, who is like the preeclampsia, like, you know, top of the charts. Everyone who has a question about preeclampsia refers to this doctor, that he does most of the research on preeclampsia. And even he will admit that we don't truly have a full understanding of preeclampsia, and particularly its pathophysiology, like what brings it on. There's many things that have been postulated. There's a lot of hypothesis. Some of it is hormonal. Some of it may be diet. Some of it most certainly are predispositions, such as one having high blood pressure already, one being overweight or obese, particularly maybe even the stress of racism. All of those things definitely can play a role. Now, in reference to what do we do about it to decrease our risk? Well, one, it's very important that we see doctors in between pregnancies. A lot of women don't do that because you got to start from a good place to optimize the possibility of you having a good outcome. So if you have high blood pressure already, it's probably not a great idea to start the pregnancy with your pressures being crazy. You want to make sure you get that under control before pregnancy. And you want to make sure you have the proper diet and exercise for your own chronic illnesses, because most of those actually predispose one to preeclampsia. Now, can diet alone treat it? Absolutely not. I think preeclampsia is definitely multifactorial. There's many things that's probably causing it, and there's not going to be a one anything fix all. I think diet is extremely important as a part of the physical, but the aspirin is key, to be quite frank. It's also not an end all be all, because it really only decreases the risk of preeclampsia by 30%. But it's the best that we have from a medication standpoint. And there's a lot of research that's coming out now that's actually stipulating that maybe all pregnancies should be given a low dose of baby aspirin. It's been looked at to maybe even decrease preterm birth, and definitely anything that has a process with the inflammatory process of our bodies. So a low dose aspirin really is low risk, which means it's probably not going to do anything to harm you. The risk of it harming you is very, very small. The risk of it benefiting you, though, is very great. So it's very important that people are on a low dose aspirin if they have risk factors, because that's the first thing I check. If I have a mother and she's a Black woman and she, whatever other risk factors she may have, I make sure that she knows at 12 weeks, get on your low dose aspirin, because it's the least you can do. It's not going to prevent everything, but it's one thing that can make a difference most certainly. So I strongly encourage a both and approach. And another thing I think that we don't really talk about too is how much the mental affects the physical. I know this is sort of a medical talk, but you guys are a faith-based organization, and I'm also very much someone who believes the spiritual affects the physical. And so I think being in a good spiritual space, being in a positive space, being centered, all of those things really affect how your body responds in pregnancy and your risk factors as well.
Hello? Am I
Thank
muted?
you.
Yeah.
I'm sorry.
Can you hear me?
Yes, ma'am.
Okay, I'd like to ask Dr. Bennett or anyone else who can discuss this, and that is, what's the role of or what's your experience with mental illness, depression, bipolar disease, and other things that have already been diagnosed within, within the population? How do you interface with psychiatry? Do you interface with psychiatrists, or how do you handle it?
I wanted to say something in regards to that, but not directly in response to what you're talking about. But I was thinking about the situation that we have been placed in with COVID and maternal mortality and pregnant ladies and postpartum depression. Because someone had brought it up, and you brought this up, and I was, I don't work in the OB field, and I'm not in that area, but the doctor does, and I was just wondering whether or not there's been an increase in the area of depression, postpartum depression. Maxine had asked me to look up postpartum depression, be prepared to speak on that area, in that area. And I didn't go into it too much because I noticed that recently, looking in the paper, we've been finding a lot of babies being found in the trash, I don't know whether or not that has anything to do with COVID and the stress from all of the deaths or the situation today. And I don't know whether or not, and I'm not prepared to deal with any on the spot answers because I'm not a psychiatrist and I'm not in that field. But I was wondering, Doctor, if you could give a better answer than I can in regards to the postpartum depression responses and behaviors of people who have had, and whether or not there's a connection with COVID and the depressions and postpartum depression or anything. Is there a connection? Do you think that possibly could be?
I definitely think that there could be. So I'm not a psychologist or psychiatrist either, but I did actually get my bachelor's degree in psychology. So I like to pretend like I have a small little psychology hat over here. And I most certainly think that COVID will have a significant impact on us all from a mental state. And most certainly in speaking to my psychiatry colleagues, they have seen definitely an increase in depression, anxiety, and other psychiatry diagnoses. In regards to how we interface in pregnancy, for me, when I have a mother who already carries a psychiatric diagnosis, I want to make sure that they are already plugged in with additional care because I want them to have support from every angle. And what I try to do is I try to normalize postpartum depression because I think in our community, for one, many times, too often, we don't take psychiatric illnesses seriously as we do physical ailments. And that's something that definitely we as a community need to work on sort of that acceptance and normalization, because I think the stigma really decreases the chance that people are going to get help and therefore enables them to be put in a position where they potentially may even harm themselves or have worse outcomes in pregnancy. And I do think that in many ways interplays with a lot of other medical comorbidities that can happen throughout the pregnancy. So I like to make sure they're already plugged in with a psychologist or a psychiatrist. Stopping your meds, because this happens a lot. So I'll say this for everyone. Stopping your meds if you are on medication for a psychiatric disorder is probably the worst thing that you can do. It is probably one of the most harmful suggestions that people think is the right thing to do or actually get told by their doctors to do. And it is literally, I can't emphasize this enough. Stay on your medication and see a doctor as soon as possible to see if you may need to tweak, switch, or decrease. But stopping your medication, I have had to take care of people who have attempted suicide merely because they got pregnant. They thought it was the right thing to do is to just stop the medication immediately. And then they attempted suicide. And I think the stigma of not getting help is just leading us to be in a bad place. Just yesterday, I won't share too much details for HIPAA, but I had a young Black patient who had a poor pregnancy outcome in her prior pregnancy. And now she had a minor complication in this pregnancy. There was something potentially wrong with the baby, but nothing that would cause harm in regards to like death of the baby. But because she had a poor outcome that she hadn't dealt with before and she didn't seek help and she never saw a psychiatrist and she had her grandmother there, she had support, but she didn't have all the right resources, mostly because of stigma. And she came in my room telling me, I'm anxious, I have anxiety, I'm going to be thinking about this, all the things that point to, I mean, she was saying it herself that she has anxiety and very much was seemingly wanted help. But when I mentioned a psychiatrist, she was offended. I don't want to see a psychiatrist, and that happens a lot. I don't want people to think that I'm crazy. And that's very much a common, like that. I can pretty much say that happens for many, many patients. It could be many, many patients. And I think that's because of the stigma in our community that's really prohibiting people from getting help. I mean, it's my first encounter with this patient, but by the end, we developed a relationship and we, I think, are making some bridges in order to destigmatize that, because for one, my personal opinion is that all Black people need a therapist because we done been through a lot. That's just my own personal opinion, especially if then something else happens to you on top of being Black in America. We really got to work on just normalizing that, whether it's through our faith-based systems, our pastors, within our churches, but also I think even within our churches and our faith-based organizations to really push both agendas. I think the spiritual and the mental need to work together.
And I would definitely say, as a clinical psychiatric social worker, the rates of depression are going up through COVID. I would say to you and submit that the stressors and the trauma have if they were fourfold before, they are tenfold now. The trauma just keeps going. So for women who are pregnant and men who are supporting those that are pregnant, it is a trying time. And that does not help in terms of having healthy babies, healthy family systems. And so there are critical roles as houses of worship and as community stakeholders that we can play by sharing this information, by encouraging and destigmatizing and talking about what the issues are. Maxine, I see your hands up, so I will.
Always. My question is, we have, asking about, I guess, the criminalization of postpartum depression. When I had my children, you stayed in the hospital forever. You know, I had 2 C-sections, so I was in the hospital 10 days. Now they let you go home very early, but postpartum depression comes in a lot. And a lot of these Black children, babies are being left in put in garbage cans and stuff like that. And the mother's being criminally charged with, with murder or whatever you want to call it, which you don't hear a lot in the white community. How do we address that? That these women are now postpartum depressed who went home and they killed the babies. Terry, Desiree.
Dr. Bennett, you want to go first? So I think from a nursing standpoint, again, being the advocate and really assessing and knowing your patient. Sometimes, you don't see it right away, but when you do see the signs as a healthcare provider, really advocating and, at least I'll give like a brief synopsis of like how you would discharge a patient. The team will come around, make sure that the patient is clinically stable and ready to go home. They put in the order. The nurse gets the paperwork together, takes out the IVs, gives them discharge instructions, tells them about medications, all this other stuff. But then there are some instances where that discharge order is in and you in your gut know that the patient isn't ready to go. Mm-hmm. And so for nurses, really putting our critical thinking cap on and really watching out and knowing that, postpartum depression is a thing and really putting our hats on and keeping our third eye open to making sure that is this patient really ready to go home and fighting if necessary with, the team, with bed control, with whoever to say, listen, this patient isn't really ready to go, and really pushing forward to making sure that that patient has the support that they need and that they have the resources that they need before they leave the hospital is one of the big things I think from a nursing standpoint, and making sure that everything is, together. I'm not sure outside of that, Dr. Bennett can touch on that a little bit more, but I think that's one of the things that I think of, like when I know for sure a patient isn't ready to go home, I will call, I've even called attendings, before on the floor, and I've said, hey, doctor, like, I just really don't think your patient is ready to go home. And that comes with being comfortable with saying like, hey, this is my patient just as much as it's your patient. And I will feel liable if something happened to this patient outside of that. And I can only imagine when it comes to postpartum depression, you're bringing home a baby, you're feeling anxious, you're feeling worried, and you're feeling all of the things. And maybe you're by yourself. So just making sure that you advocate for the patient from a nursing standpoint.
I think this is why, again, the team approach particularly to OB care is so important, because to be quite frank, the nurse is the savior of the labor floor and the postpartum floor. As the physician, I'm not going to be interfacing with that patient quite as frequently as her nurse. And so I think it's very important, especially when nurses feel emboldened and a true part of the team, to be able to call that doctor and say, hey, I know you think she's going home today, but I really don't think that's a good idea. And for there to be that relationship where that communication can happen seamlessly and the appropriate change can be made. So definitely, I think nurses speaking up in regards to when they see those signs. And particularly in many hospital systems, they have social work clearance for all of the mothers. And if there's signs that seem to be pointing to a higher risk of a postpartum depression state, there's certain follow-ups that can be scheduled earlier and things like that. In addition to the question for the specific criminalization of these cases when there is a bad outcome from a postpartum depression, it's hard to say. I mean, I would hope that in those instances, those patients can be, or those people can be advocated for and not be criminalized if they have a psychiatric disorder that explains the terrible outcome, because we all failed that person, not necessarily, you know, the bad thing that happened at the end. So I think there's definitely a role there for, again, policy changes, but also for advocacy from physicians and clinicians as well.
And just as a follow-up to that, I think as community, as health ministries, we also have a responsibility to destigmatize mental health, depression, not to just say, oh, baby, don't worry about it, just pray on it, it'll go away. That's good, we need that, but sometimes we also need the help of the physician. And that's, you know, a team approach. We pray and we also go to the physician who can help and provide the support. So we as health ministries, as people in the community who are supporting our families, who are working in community-based organizations, have that role also to reach out, talk to one another, destigmatize mental health, so that we can have people feel free that they can come forward and say, I need help. And it's okay as a Black woman to say, I am not Superwoman. I cannot do it all. So we are down to our last 5 minutes. And I would like each of our panelists to have a closing statement so that we can bring this all together. Again, if there are any questions that haven't been answered, please feel free to put them in the chat, and we will send out the recording and any answers that we did not get to you. Pastor, would you like to start?
Pastor, I guess that's me.
Yes.
Closing statements. I sincerely hope that we were able to do what we set out to do, was answer any questions or provide any information that we set out to do. Although this is a wide area, and there's so much more information that we could have given. It's too wide an area, and I wasn't quite sure what I should have covered, you know, in such a short period of time. And I'm sure that we can always go back over this and come back and revisit this area. I'm sure we can. I hope I was helpful, at least.
Thank you. There's a note in the chat that if the panelists are willing to put their contact information into the chat, we would ask that you do that. Dr. Bennett, would you like to, Desiree or Dr. Bennett, who would like to go next? Dr. Bennett, go ahead.
Yeah, I just want to say, you know, Black women, you are everything. You are all powerful. And I know at the end of the day, we try to save the world, but we really sometimes have to focus on saving ourselves. And please know that as healthcare professionals, we are working to change this system, to create an environment where it's safe to give birth and where the anxiety and the angst of Black women dying in America can once and for all be put to rest. But I just want everyone to know that the work is being done on the back end. We are changing healthcare. We are working to make medicine safer for all of us, especially Black women. And I just want to express my love and gratitude for being a Black woman, and that I'm here for anyone who needs direction or help. I don't have all the answers, but I sure am never afraid to ask a question and to be a resource to my community. You know, I tell all of my family and friends that I didn't go to med school and become a physician to sort of be a part of this system. I really want to be a disruptor of this system, and I want to especially be there for my loved ones, which now include all of you. So thank you, Terry, for inviting me here this evening. And I'm just very grateful to be able to share whatever knowledge I may have. And I thank you again for inviting me tonight.
Thank you. Desiree?
Yeah, so just honestly to piggyback off of what everyone had said, thank you to Miss Maxine for reaching out to me earlier about the event. I really hope that everyone does feel empowered and does walk away with a little bit of knowledge and feel a little bit of relief of, seeing Black women and, Black and brown women, in healthcare who are really trying to change this for the better of the community and for health. And, this is definitely a for us, by us type system, and really coming together as a community. And that's what we need. We need conversations like this. We need to spread the knowledge as much as we can to let people know that we support you, we see you, and for us to really be change makers in this. And whether you're a clinician or not, being an advocate doesn't take a degree. It doesn't take, much of anything, but you being able to stand up and support your loved ones as they go through processes such as labor, such as delivery, such as pregnancy. Those are all very important, and it makes a difference. And, in the coming years, we all, hope to see that the research shows that Black mortality rates are decreasing and the incidences of Black mothers and Black babies who are dying are decreasing. And we hope to see more Black and brown doctors, nurses, nurse practitioners, doulas, midwives everywhere, because it's necessary. We have to have that support, and we definitely have to have that in our community. And for our faith-based organizations, continue to do what you do. Shout out, to my church, Bethel. I owe, over the coming years, and Miss Maxine being the head of health and ministry there, just to even see that evolution and to really see that process, continue to use those important places as resources and, places as knowledge, knowledge-based centers, not just for the word, but for the word when it comes to the health of our bodies. So thank you all for having me. And yeah, I look forward to another conversation.
Thank you.
So thank you. It looks like we have come to an end. I want to say thank you to both Maxine and Terry for putting up with me as we put this panel together. I want to thank you all for an opportunity to be able to, yes, Pastor?
I want to say one thing before we leave. I think when I grew up, I think, I don't know about you, I'm probably the oldest one in the panel. I am. And I'm going to say something that when I grew up, I grew up learning the golden rule. And one of the things in that golden rule, the one thing about that golden rule is that I learned was that you should do unto others as you would have them to do unto you. And so I think that we should all remember to do that. And that's what I think that this panel has taught me, that we set out to do unto others, that as we would have them do unto us. And what we must remember to do is that we are seeing us die, and we set out to help keep each other from dying. And that is reaching out to the corners of the world, as the scripture has told us that we should do. Reach out to the corners of the world and spread the word of God to spread the word of God. And we got to love our neighbors as ourselves, which is what that golden rule has always meant to me. And that's what I think that this panel is teaching us to do, and has said to us to do to each other, to love our neighbors as ourselves, and to do unto others as we would have others do unto us. I fumble a lot, but I think I'm trying to get something where I'm saying what's in my heart out, that we are to do unto others as we would have them do unto us, and love our neighbors as ourselves. And with that, I'll stop.
I just want to thank everybody for coming on, who came on, and I just love all the speakers. Dr. Terri, I might have to use you again. I can always find Desiree because she goes to my church, but this was amazing. We could have done this in 10 hours. This was something that is so much more to learn about, to talk about, but I'm glad we got the basis right here, and that we all can learn to advocate for our people. We learned a little more information than we had, and we can learn to apply it. We are the woman, like you said, the woman rule this world, and we have a lot more to do, and this is just a basis of what we learned. So I thank Deborah for tolerating me too, and Terry for being here. And that's what I have to say. Thank you all.
So thank you on behalf of the SUNY School of Public Health and Health Policy. It is always our honor and our privilege to create spaces where honest dialogues can happen. Wishing you all well, and just remember that we need to be forward focused and not past possessed. Thank you all. Have a great evening, and we'll be sure to get this recording out to you as soon as possible. Thank you.